Hi, you're listening to It Happened to Me, a rare disease and medical challenges podcast. The mission of our podcast is to support you, our listeners, and to create community as you confront the toughest challenges in life. All of us will experience health hardships. The real question is how we adapt. That's the focus of It Happened to Me, which wants to help you overcome limitations and live a full and satisfying life. Drawing on their own health challenges, co-hosts Kathy Gildenhorn and Beth Glassman interview guests who share stories and research to help you succeed in the face of difficult health obstacles. It happened to me. I'm not alone, and neither are you.
Amy is a licensed pediatric and adult genetic counselor. She works at the Johns Hopkins Department of Genetic Medicine. She primarily works with patients at the Greenberg Center for Skeletal Dysplasia, as well as the Genetic General Clinic. Amy earned her Master's of Science at Boston University.
Amy initially started advocating in the rare disease space due to her best friend's siblings to rare genetic disorder, congenital hyperinsulinism. Over the years, she has served in roles at the Rare Action Network, RAN, which is the advocacy branch of NORD, the National Organization of Rare Diseases. She's now the RAN Massachusetts State Ambassador, and she has also started hosting Rare Disease Day events at Boston Children's Hospital and now at Johns Hopkins Hospital.
Amy, welcome to It Happened to Me. Can you tell us what you do at Johns Hopkins as a licensed pediatric and adult genetic counselor?
Yes, I would be happy to. And first and foremost, though, thank you so much for having me on. I'm very excited to be here today. So, like you mentioned, I work at Johns Hopkins. I've been there for about 3 years now in this role. And so as a genetic counselor, I work with patients and families and other providers in the general genetics and skeletal dysplasia space. That typically entails me meeting families and talking to them about whatever their concern is from a genetic disorder, genetic condition standpoint. Is there a genetic condition in their family? Is it something that their child is presenting with signs and symptoms? And through which I might collect clinical history, developmental history, family history, talk about informed consenting for genetic testing, as well as potential genetic testing options to help maybe reach a diagnosis if a geneticist feels like something, maybe fitting together or there are symptoms in more than 2 or 3 organ systems. And then if we do genetic testing, I'm often one of the first contacts disclosing those results and talking through what they may mean for that family, and then also giving them various support resources to help, whether it's understanding a new diagnosis or coping or helping them grieve in an appropriate way, or connecting them with other families to maybe this is a joyous occasion. They're looking to build a support network. And so I kind of hit a lot of different avenues. A lot of genetic counselors play a very multifaceted role. And I feel very lucky to be able to work with families kind of from start to finish throughout the diagnostic odyssey and beyond.
Amy, I would say, just listening to your response, that the families in your care are very fortunate, because some of these conversations, it sounds like, are going to be difficult and mystifying. And you are a clear, articulate speaker and a compassionate person. So I would say they're lucky to be in your care.
Appreciate that.
Part of your background is in advocacy, and you've been very active in that space. So can you explain to us what conditions are rare?
Yes, absolutely. That's a question that I get a lot. And interestingly, there is actually no standard global definition of rare disease,
Really?
which kind of comes as a surprise.
That's surprising.
It differs by country. So at least in the US, a condition or a disease is considered rare if it affects fewer than 200,000 individuals. I do know the stat for Europe. For the European Union, they define it as affecting fewer than 1 in 2,000 persons at any point in time. And so a little bit different. The numbers actually relatively equal out, just slightly different wording. Similarly, there's a definition for ultra rare disorders in the US as affecting fewer than 1 in 50,000 individuals.
Gotcha. So we've talked about how many people are considered to have rare diseases, ultra rare diseases worldwide. So speaking, you are also, as well as an adult counselor, you are also a pediatric counselor. So what childhood diseases would be included in the rare disease category?
That's a great question. And I don't know if I have a perfect answer for this, although, so rare diseases and rare disorders can affect someone throughout the lifespan. There's many that are diagnosed prenatally or at birth. There are plenty that start showing symptoms throughout the adolescent period, and then another chunk that may present much later in life, 60s, 70s, 80s. Importantly, and something that we use as a talking point, especially when advocating to politicians or people that are not immediately in the healthcare space, to really bring it home, all pediatric cancers are considered rare disorders, just as a blanket statement.
Sometimes so pediatric cancer would be children under the age of what?
Of 18.
Of 18. Okay. Any cancer under the age of 18 would be considered rare, a rare condition, I think.
And sometimes that helps it hit a little bit close to home for policymakers, whether they know someone specifically or just have worked on other policy related to cancers. I mean, cancer is something that unfortunately likely touches everyone in some
in some
terrible. Yeah.
Now I'm wondering, to go back to rare and nano rare diseases. You were talking about the numbers, but is it simply the numbers, or is there a connection to the root cause of the disease, such as an infection or genetics? Is that also a consideration in the definition?
Yeah, great question. So most rare disorders have a genetic origin, but there can be environmental factors that can cause rare conditions, as well as infectious diseases that are considered rare as well. So it doesn't have to be a genetic condition. It doesn't have to be able to find that exact genetic variant in exactly that gene that causes it. When we're bucketing conditions by rare versus ultra rare versus nano, or some people call them N of 1, so affecting one person or a very small population, it really currently does have to do with the number of people affected. So that is what is defining those buckets. There is actually a little bit of debate in the field as to what is the utility of bucketing like that. Do we actually need to think about them as rare versus ultra rare if a lot of the same challenges or barriers or stigmas are affecting that whole category? But I did my capstone research or my master's thesis on rare disease patient advocacy groups. And to me, and this may not be everyone in the field, to me, I do find it a little bit useful to bucket these conditions out, because that actually shows us that everything from the isolation to the lack of treatments to the lack of specialized care centers that we see affecting the rare disease patients are almost further exacerbated in that ultra rare or that N of 1 or nano group, because it's that much more rare. You're not going to be able to find perhaps even another person in your country with the same rare condition, let alone one researcher who is actually studying this exact thing or creating a mouse model or creating a treatment. And so we see the issues really, really exacerbated as we get into these smaller numbers.
Okay, and can a rare disease be diagnosed at any point in life? I look at myself. I was diagnosed with a rare disease at age 64, 65.
Right. And that's a great point. So actually, one of the conditions that I primarily see in the skeletal dysplasia clinic, something called hypophosphatasia, that's actually a unique rare condition in which you can present with symptoms at any point in time in the lifespan. So sometimes we're diagnosing babies with a very severe form of hypophosphatasia that typically presents with kind of abnormalities of the skeletal system, meaning the skeleton isn't fully formed. And then we actually see another form of the condition presenting a little bit later on in life, maybe in adolescence with more fractures, low trauma fractures. And then actually the majority of my patients are people in their 50s, 60s, 70s.
Oh, really?
Who get diagnosed that late in life, kind of similar to, because we're seeing they're getting flagged by their primary care physician or their endocrinologist for having much lower bone density than expected for their age. So we naturally think about low bone density kind of arising, especially in females post-menopause with hormone changes, but we just see bone density plummet much further than expected with hypophosphatasia. So to me, that's just a good example. We could be diagnosing this at any point in time based on how they present with symptoms, but that genetic condition has been present in them since birth and since before birth. It's just a matter of when they present with symptoms. And
so basically pulling it all together, it seems like I was going to ask who should be aware of rare diseases, but I think it's more important to know we all should, and that it can happen at any stage in life. So are the genetic screening panels available only when you're trying to conceive or you're currently pregnant, or are there some for later in life? Are there genetic panels that skeletal dysplasia or other rare diseases are present on?
Yes, so there are some very commonly used genetic screenings and genetic tests that are done, especially, in the prenatal space and in the immediate neonatal or newborn period. For instance, with genetic testing just becoming much more accessible, we see in the prenatal space, like you were talking about with J-screen, with other things, just broader carrier screening or expanded carrier screening, those panels are looking for common or relatively common, rare recessive conditions.
Right.
When you need to have two genetic variants, one passed from mom and one passed from dad. So carrier screening in one way or another, whether it's J-screen or a small panel or a 450 gene or genetic disorder panel, is often being offered to pregnant people these days to better understand the risks to their fetus in the future, and to help them make pregnancy decisions. And yes, not everyone is getting offered this. It does come with a little bit of privilege in the sense of, where do you live? Is there someone, do you have an MFM or a prenatal team that can offer this kind of thing? Do you have money or insurance to pay for this? But it is being offered. And then the next screen that is offered typically early in pregnancy, once someone actually conceives and it has a successful pregnancy beginning, there's something called cell-free DNA screening, which again is a screening test to look for relatively, again, I was going to say common, but my common is a biased common because I work in the rare disease space. Right. So the conditions that we often think about detecting in the prenatal period, so things like Down syndrome, trisomy 13, trisomy 18. And then this screening test also looks for the sex chromosomes and can tell you the sex of the pregnancy. More recently, they've been able to expand this testing to include certain disorders like skeletal conditions. So One of the more common ones that I work with is actually the most common skeletal dysplasia, achondroplasia. That is now included on these cell-free or non-invasive prenatal screens. So I should have explained a little bit earlier that this screen really was developed because a lot of pregnant individuals were not interested in having diagnostic or invasive genetic testing where you need to have an amniocentesis or grab cells from the placenta. This just takes blood from the mother and is actually able to pull out the fetus's DNA from the mother's DNA.
Wow.
Oh, isn't that something?
That's
amazing.
something.
It's a really, really interesting technology.
It's a big step forward. Yeah, it's a big step forward because we can understand that there's a risk with amniocentesis. And for many women, it's so difficult to conceive. And so to take a risk would not be something they would want to consider. So isn't that a wonderful step forward? Amy, I wanted to ask you, how about screening for infants once they're born? I am a proud grandma and just had a new grandchild born 6 weeks ago. So I'm wondering what testing was done for my little grandson, and are all children tested the same from state to state?
That's a great question, and congratulations.
Thank you so much.
Incredible.
Thank you.
Absolutely.
Yes.
So most likely your grandson had something called newborn screening, which is a state by state policy, but it's actually recommended by the federal government. So every state has their own panel of conditions that they test for. That being said, each state's panel is built based on the federal recommendations for something called the RUSP, the Recommended Uniform Screening Program. And so it basically puts forth a set of treatable genetic conditions that they recommend every newborn is screened for, because again, that key is treatable, meaning most of these conditions that are approved to be on these panels, if you can detect them early, there's typically some kind of diet or formula modification that actually treats these children and prevents the possible complications down the line.
Wow.
Oh, isn't this wonderful?
That's incredible.
Oh, that's terrific. So then would rare diseases be included in this panel?
So this panel, and I will fact check this afterwards as well, but this panel includes only rare conditions, actually.
I see. Okay.
So it is focused on rare genetic disorders. One common one that you may have come across, or a lot of the listeners may have at least heard about, is PKU, phenylketonuria. That's actually the first condition and the reason that this screening tool was developed, because back in the 60s and 70s, some really intelligent researchers, doctors, were able to find that just from a heel stick of blood, so it's just a little like pinprick of blood from the heel, they're able to find a biochemical lab finding that tells us, do we think this is PKU, phenylketonuria, or does it not seem like there's any risk of that? And then if there is what's considered a higher risk for one of these conditions, then they'll get diagnostic genetic testing after this to confirm.
So we're discussing rare diseases and the impact that it's going to have on the family. And this might be a good time to talk about advocacy groups. You are very involved in this field. What can you tell us about advocacy groups? Do they exist, and do you recommend them?
Yes, they do exist, and I definitely recommend them. Patient advocacy groups are the lifeblood for rare disease patients and families, and even we can learn so much from them as providers in the rare space. Patient advocacy groups traditionally were founded by motivated parents or motivated families to help support their child or their loved one with a rare condition, to help them build community, to help them find, potentially treatments that could help them, to help them find motivated researchers or doctors who know something about this rare condition. Oftentimes, before the internet, before even major easy communication through social media and phones and things like that, patients really had to rely on writing to each other to say, who's the doctor you use? We're across the country. How can we see this person? Because maybe that doctor is the only doctor who has treated someone with that condition or has studied someone with that condition. So rare disease patient advocacy groups were really founded to help make those connections and find a support system. And a support system could be everything from, purely community, being able to empathize and really understand another person who's experiencing similar things to you. And maybe you don't have anyone that you feel like you can talk to about your symptoms or about your day-to-day or the stigma that you've faced or whatever it may be. And so again, community is a big piece. One of the really more amazing triumphs of a lot of rare disease patient advocacy groups over the past maybe 20 years is getting involved much more significantly in research. And that can be in a lot of different ways. Patient advocacy groups often are the ones, that know what are the clear endpoints that people in their rare community actually want from a clinical trial, meaning what do patients actually want out of a treatment? If we can't reach a full cure, if that's even the goal, what are the symptoms that are the biggest priority for effectively reducing or treating or alleviating? On top of that, patient advocacy groups are able, patients are the experts on themselves and their bodies. And so a lot of times patient advocacy groups are advocating either directly to pharmaceutical companies or to government programs to help facilitate funding for researchers to help drive drug development or help drive research on their condition. So a big piece of it is funding and crowdsourcing and things like that. So the drug development piece and the community coming together and sharing resources. An organization that I have the privilege of working with, the Little People of America organization, they really are able to share various accommodations that either individuals have developed themselves or accommodations that they found online, because Little People of America is a large advocacy group, patient support group for individuals who are short stature, have dwarfism, or are considered LPs, little people. And so individuals in that population are often trying to share tips for, what are the best step stools, or how do I get my clothing tailored? Where do I find a prom dress that fits my body? Where are the best pedal extenders for driving and things like that? So that's something that I, as a provider, and I, as a person who is average stature, will never have that full experience and will never be able to know what that feels like. And people really need to rely on themselves and then ideally share back with me so that I can continue to spread those tips and tools to my patients as well.
It's so interesting how important these advocacy groups are, that it's not, we think of advocacy groups, and Kathy and I have talked to so many people, that advocacy groups provide community and support, but you're also talking about how researchers should think about what their end goals should be. What a fascinating idea. And who better to tell than the patient?
Right.
This is a wonderful, so I'm so glad that these advocacy groups are there to help people. Now, Amy, I think something that has always been said is that if you have a condition, you want to have a lot of company, meaning that You want to have a condition that a lot of people have because research money goes into it and insurance will cover the cost. So here we are with a rare disease community who doesn't have as much company as other conditions. So what is the role of government? What is the role of state governments in particular to help individuals in the rare disease community get insurance coverage for their treatment?
That's a great question. And I think we could spend hours and hours on that too. And I'll just share even just a little bit about my thoughts on that, state governments, I mean, there are a bunch of different avenues we can go with this, that the Medicaid programs are state programs that were developed through the Affordable Care Act. And that really,
so that's fairly recent.
Right.
The Obamacare is very recent.
Mm-hmm. The
Interesting.
Yeah, exactly.
Yes.
The Affordable Care Act established a set of really, really significant protections that benefit individuals with rare diseases. One of the big things that affects not only rare diseases, but a lot of people, anyone with a pre-existing condition, is that insurers can't deny you based on having a pre-existing condition, which is great. And they also can't charge more. They can't have higher premiums based on an existing pre-existing condition. So Medicaid can be, again, state-based program. There can be slight differences state by state. One of the big things that I'm sure there are more informed individuals out there than me that could talk about this for an entire hour, but 1115 waivers, is that something that you guys have talked about on the podcast before?
No.
Okay.
No, we're not familiar with that.
1115 waivers are basically programs that through Medicaid, it allows a little bit of flexibility actually with state Medicaid programs in which they can use federal funding to implement an experimental or like a new policy that is going to be a short-lived policy to really test it out. And then if they, through research, it shows to be beneficial, then it may actually be implemented at the state level in a permanent fixture. But these 1115 waivers allow for this kind of short-term tryout policy, essentially with federal funding.
Sure.
And so some of the states that are using 1115 waivers right now are really using them to implement policies that improve equity in healthcare for patients in that state. Equity is a big thing that we talk about in the rare disease space, and these 1115 waivers are working to build better healthcare policy to support rare disease patients of color, of racial and ethnic minorities, of low income, to better help them access quality healthcare in their state. And maybe that includes genetic testing when some families wouldn't have previously been able to afford or access genetic testing.
Yeah. So
like
the genetic counselor is really a crucial part in this whole process between the diagnosis and getting appropriate care.
Yes. Yeah. I mean, I like to think so. I'm a little bit biased, but I do think from my perspective, we are able to really think about the patient from a holistic mindset. I mean, I'm very fortunate that I get to meet, typically in the postnatal space where I am, I get to meet a family unit. I get to see what those family dynamics are, what the social context and the living situation is for that child or that individual with the rare condition. I get to take into account everything from their culture and identity or their faith, if that's part of it, to help really counsel the patient effectively and try to support them and meet them where they are at. And sometimes that takes the form of advocacy, of seeing an issue for my family and saying, well, that was that was wrong. They couldn't access this because of this policy. And to me, I really do feel like that we are able to work with so many patients and families and hear their stories and hear what would benefit them. And ideally, a lot of us will take that and kind of run with that in terms of state or federal policy. I know, everyone's very busy, but those that are interested at all in state or federal legislation, I hope are getting involved. One big thing that is a state-based policy, actually back to your previous question, that really is directly going to affect rare disease patients and families and research on rare disease in each state is something called the Rare Disease Advisory Council. So that's the Rare Disease Advisory Council, or the RDAC, is a state-based legislative body made up of rare disease stakeholders. That could be patients, patient advocacy groups, researchers, genetic counselors, geneticists, all coming together. Most RDACs that are in existence are through the governor. The governor appoints people to this RDAC to really serve as a voice for rare disease patients at the state government level. It's not going to take away the fact that we all need to keep pushing and advocating and sharing our stories and sharing our voices, but at least people can kind of trust that there is a body, a formal consortium that is ready to listen and has understanding already about rare disease and the burden of rare disease at the state level.
To anyone who is listening, who has a friend or a relative with a rare disease, there is so much help out there, but may be quite overwhelmed. And I can see that the role of the genetic counselor, it just seems we need to really beat the bandwagon. Please go see a genetic counselor, because they can help you not only with the diagnostic, with treatment, but getting coverage. I mean, there is no point in getting the help if you are blocked because of your inability to pay. And so the genetic counselor can help you get through this tangle of mess that sometimes legislation is, to find an answer and find a way for help. I think this is wonderful news, Amy. Thank you.
Of course. I am definitely involved in insurance pre-authorizations and writing letters of support and things like that. So,
oh my goodness,
that's not going away.
Yeah.
So important. Thank you.
So thank you. I was wondering, how long does it take to get a diagnosis of a rare disease, and then how can we shorten that journey? I know I personally, it took me 15 years to really get there. And is that typical?
Unfortunately, Kathy, I do hear a lot of times kind of a similar story to what you're sharing, that right now, on average, at least the National Organization for Rare Disorders cites about an 8 to 10 year diagnostic odyssey for most individuals. And that people ask me kind of why that may occur. And sometimes, it gets at a little bit of what we've been talking about, that does that individual or family have access to an academic medical center or a medical center that offers genetic testing, or has a geneticist or has a genetic counselor, and does their pediatrician know to make certain referrals? And it's a lot of families are bounced around from specialist to specialist to specialist before someone saying, oh, let's look at the whole body. Let's think about why you need to see all these different specialists. And oftentimes, and that takes years.
Do you think
sometimes.
Genetics and genetic counseling can be a real key to shortening this journey?
I think being referred to a genetics clinic, whether or not there's a genetic counselor, I personally think a genetic counselor can be very helpful from a counseling standpoint, psychosocial standpoint, diagnostic standpoint. But getting to any genetics clinic, to be able to have someone, a geneticist, do a full body, a clinical exam a physical exam. At the same time, they may also be ordering labs, they may be getting imaging. We really do need a complete picture of what is going on as far as we can see from your body, from your bones, from your labs, from how your brain is functioning. And then based on any of those findings, a geneticist is trained and a genetic counselor is trained to think about the genetic testing options to try to reach a diagnosis. Reducing that diagnostic odyssey is even a little bit more complicated than that, unfortunately, that it comes down to how diverse is our data in genetic test databases and population databases. Do we have an accurate representation of racial and ethnic diversity in data? Because that actually can skew whether or not people of racial and ethnic minorities reach a diagnosis at the same rate as individuals of European descent.
It's also complicated. I mean, the genetic side is as complicated as the diagnostic side. I mean, it's really, there's a lot to think about. And what does the future look like for individuals with rare diseases?
I think the future hopefully is looking like more access to qualified healthcare providers who may be actually experts in their rare disease space. And that's really going to come from, global collaboration and collaboration among all stakeholders. Like we were talking about earlier, we need patient advocacy groups talking to drug developers. We need policymakers working with physicians and working with patients and working with genetic counselors. We need this to be a multifaceted approach to be able to speed up drug development, increase access to things like genetic counseling, genetic testing, and even telehealth services, telemedicine services have really helped patients connect with qualified healthcare facilities or centers of excellence. It's got to be a multifaceted approach to be able to reduce that diagnostic odyssey and connect families and work towards drug development, at least for conditions that are looking for treatments.
Wow.
Let's hope that happens soon.
Let's
hope that happens soon for so many people.
Absolutely. Is there any parting advice that you would have for listeners facing or suspecting a rare disease?
Yeah, so I have two brief pieces that I would like to bring up. That if you are suspicious of, if you're a family and or a parent that you're suspicious of something different about your child, you can trust those instincts. Go to your pediatrician, tell someone, share something. It doesn't even have to be a child. If you are worried about your own health, bring that to a doctor and
be your own best advocate.
Be an advocate and use your voice, because instinct is what a lot of people go on and to reach these kind of diagnoses. There is a tool on the National Society of Genetic Counselors website, NSGC, where you can find a genetic counselor in your state or in your area. And that could even serve as an initial contact. And then we're trained to make sure you get the right referrals or make sure that you get to the right, to the genetics clinic, and we'll help facilitate that. My other piece that I would love to impart is for those who are going through a diagnosis or reaching a diagnosis, I always try to help people understand that your reaction to a diagnosis, whatever it is okay. You could be feeling joy, you could be feeling relief from reaching an answer after all this time, but a lot of times there also may be grieving. There may be a change or a loss of expectations. And whatever point you're at is okay. There's not a predetermined notion that you have to feel a certain way, or we as your providers are expecting you to feel a certain way. On top of that, some genetic conditions like achondroplasia and other skeletal dysplasias or short stature disorders, maybe they don't want a treatment, and it's something like families specifically are very excited to have a child with achondroplasia and be in this culture and this identity and feel the support and love of this community. Versus we may also come across someone, with a lethal or a lethal dysplasia or a lethal condition like we heard about in one of your other podcast episodes, that there's going to be this huge grief. And so meeting another family, you may, even in the rare space, there's going to be a lot of overlap of the challenges you may face, but there also may be totally vastly different experiences of a diagnosis.
Mm-hmm. Wow. Well, Amy, thank you for being a guest today on It Happened to Me. And thank you for sharing information and raising awareness just about rare disease, skeletal dysplasias, genetic testing. Your wisdom and your guidance are so very appreciated. Thank you so much. We've so enjoyed having you with us today.
Thank you so much for having me.
Thank you for listening to this episode of It Happened to Me. We encourage you to learn more at ithappenedtomepod.com. Please use the contact form on our website to submit your guest suggestions, comments, questions, ideas, and feedback for the show. You can also email us directly at ithappenedtomepod@gmail.com. We would really appreciate it if you can leave us a 5-star rating and review on your podcast app like Apple or Spotify. This helps others in the rare disease and medical challenge community find us. It Happened to Me is created and hosted by Kathy Gillenhorn and Beth Glassman. I'm Keira Deneen from DNA Today, and I serve as our executive producer and marketing lead. Amanda Andrioli is our associate producer. Ashlyn Anokian is our graphic designer. And remember, it happened to me. I'm not alone, and neither are you.